Thank you very much for this opportunity to speak to the MDS Hub. My name is Guillermo Garcia-Manero, and I'm the section chief of myelodysplastic syndromes at the Department of Leukemia at the University of Texas MD Anderson Cancer Center in Houston. So today we're going to be discussing how can a structural variant assessment may assist in the evaluation of patients with myelodysplastic syndromes. And this comes because of a paper that our group published in the journal Leukemia a few months ago talking about this particular topic. And I think this paper now is being used as an example or model of how to use this new technology in patients with MDS, and actually probably as useful in other types of leukemias. So let's focus on myelodysplastic syndrome. In MDS, when we evaluate patients with this condition, we use a number of parameters. The first one, of course, is the degree of cytopenia. The second is the percentage of blasts in the bone marrow. The third, most recently, is the use of next generation sequencing technologies to look for particular point mutations that are frequent and clearly associated with prognosis in this disease. But I believe that for the last 20 years, what has become more clear is that cytogenetic evaluation, so the analysis of chromosomal alterations in this disease, is actually key. And if you look at the data in detail from different NGS studies and other type of analysis, this chromosomal analysis always comes in the models as an independent feature of what NGS, and actually perhaps even more powerful compared to blast percentage in terms of prognosis. Now, of course, there is nothing new about this because we knew from AML and other leukemias that cytogenetic information is really critical. We use this very much to evaluate and determine the potential prognosis of our patients with AML. But it took a little bit more time to really determine what was the role of this information in MDS. And it was probably not until maybe 2010 and so forth, where a number of papers from the German group in collaboration with the MD Anderson group and other studies from Europe clearly showed the value of this cytogenetic information. And that all basically was put together in the cytogenetic MDS scoring system that serves actually as the scaffold of the basis of the IPSSR score that the MDS community put together almost over a decade ago or so. So the bottom line is that chromosomal analysis is critical in the assessment of prognosis of patients with myelodysplastic syndrome, whether you use these old classifications such as the IPSS or the IPSSR, or even actually if you use the more modern IPSSM classification. As you remember, the IPSSM classification is basically focusing on NGS type of technology. So this is critical. And as an MDS physician and researcher for almost 2 decades that has visited many different countries, etc., what I see as a major problem around the world is actually access to this kind of cytogenetic information. And to me, it's actually very interesting that for many years, I thought that at some point, the NGS data was gonna at some point basically supplant the importance of cytogenetics. In other words, that we were gonna get rid of it. And it turns out that that's not the case, perhaps because these big structural chromosomal changes, these big chromatin alterations that we see with this cytogenetic analysis are maybe of biological value and not the same as point mutations as we assess with NGS. So in summary, cytogenetics are critical. Now, as I was saying earlier, I think this technology that is actually quite old, and I don't say that in a pejorative way, but we have this for many years now. It's actually complex, and it's complex for a number of reasons. Number one, it requires actually enough cells to really have enough metaphases or cellular elements to count at least 20 cells. That is actually not always possible. Sometimes these specimens from our patients don't really grow in a satisfactory way. Maybe we don't have enough bone marrow aspirate fluid to really perform the assay. So it may be technically difficult. And indeed, actually, even at MD Anderson, probably around 10 to 20% of our patients will be in a category that we call insufficient metaphases. What this means is that we don't have enough cells to really count and assess cytogenetics. So that's a big problem. The second is the technique itself. This is a complex technique, although we had it for many years. And most important, it requires really experienced cytogeneticists, people that are really trained to evaluate these alterations. And this is not that common. And in many countries and even centers around the world, even in North America, we don't have this kind of manpower to really evaluate this very important information. So it turns out that in many situations, we actually don't have one of the key characteristics that we need to evaluate the prognosis of our patients with myelodysplastic syndrome. So when we had the opportunity, together with Dr. Rashmi Kanagal in the Department of Hematopathology at MD Anderson and Dr. Hui Yang in the Department of Leukemia, that are the leaders of the paper that serves as the basis for this recording, when we had the opportunity to really use this new technology, this optical genome mapping, we thought that this was a great thing for a number of reasons. First of all, this technique does not require the growth of these cells. Actually, you don't need to really have this kind of cellular material to perform the analysis. Now, you need a concentration of DNA in a large molecule type of structure, but that should be easy to obtain from a majority of our patients with myelodysplastic syndrome. And indeed, in the paper that we published in the journal Leukemia, the number of failures due to this, what will be the analogous of insufficient metaphases, actually is close to 0%. So that's actually barrier number one, that the fact that this technology does not need access to these cells that are kind of dividing so we can evaluate these metaphases makes this unlikely that you will fail because of this first issue. The second actually issue is the technology and the interpretation itself. So basically, what this new technology will do will be to, based on this high concentration chromatin or DNA will do, compared to expected normal patterns, will give you a very detailed map of the structural chromosomal changes. Now, this requires a specific device. There are a number of companies. The one that we use is called BioNano. That's what the technology that we reported in the paper. And it needs software basically to evaluate those results. Not dissimilar to maybe the way this is done for next generation sequencing, etc. Except that you're looking at this at the chromosomal level. So this may be paradoxical because you're thinking, well, how can this democratize this kind of technology when you need probably an expensive device and sophisticated software to evaluate this data? But on the other hand, basically, you don't need to have tedious technique to perform the metaphase analysis, and we probably don't need super experienced technicians to really evaluate these bands that are the basis of the traditional cytogenetic analysis. So one could think that potentially, if the cost of these devices was acceptable, you could replace really all an arcane way of evaluating these chromosomal changes by technology that could really make this quite straightforward, eliminate the rate of insufficient metaphases, and give you a detailed analysis of these chromosomal maps. And indeed, actually, it appears that the technology, as expected, is not only more specific, but more sensitive than the human eye evaluating these band patterns that are the conventional way to analyze cytogenetics. So we believe that this is going to be really important. In MDS, actually, in the paper, we saw that we were able not only to eliminate the rate of insufficient metaphases, but also to really change the staging of these patients when using IPSSR classification. So this is really important, because once you do that, then your treatment approach to that particular patient may change completely. You may go from a lower to higher risk category, as we saw with the IPSSM using NGS. And that, of course, will have tremendous implications in terms of the type of therapy that we use. And questions that we are now trying to explore in our group are, for instance, what is the value of this technology in trying to assess cytogenetic responses? So that's very important. What is the value of this technology, for instance, in evaluating clonal evolution? That is another very important aspect of this disease. So we think that this technology may, in time, supplant potentially conventional cytogenetics. It will not supplant NGS. So I see a future where we'll have our morphological assessment, flow cytometry, morphological assessment of blast percentage, and then these techniques to evaluate NGS alterations, maybe one day by whole genome sequencing. Right now at MD Anderson, we perform an 81 gene panel, and maybe this kind of cytogenetic analysis using this optical genome mapping that could replace conventional karyotyping, and for sure eliminate the need of FISH if we ever use that. My understanding is that a number of centers are starting to implement this kind of technology in so-called CLIA labs, and indeed, actually, MD Anderson already offers this technology as part of the clinical assessment in the CLIA hematopathology lab. So this is a certified laboratory that we use to, to perform our diagnostic procedures at MD Anderson. So I'm proud of this work and my colleagues. I think this is going to be of major impact, not only in MDS, but also in AML. And actually, I see a great future for other leukemias where translocations can be quite important, example being acute lymphocytic leukemia. So to summarize, this is a new technology that in our hands, as reported in this paper in Leukemia, basically eliminated the failure rate almost completely as compared to conventional cytogenetics, and may allow us to obtain more detailed chromosomal maps of our patients with its implications in terms of prognosis and therapeutic decision-making. I believe this is now becoming an active area of clinical research, looking at some of these questions that I alluded earlier, and I'm very proud to see that this is actually started to be implemented in CLIA labs, both in North America and in Europe. Thank you very much for listening to this short video.